In imaging, we've spent many years using very advanced techniques such as intravascular ultrasound or intravascular optical coherence tomography, OCT, as ways to really look at the structure and the anatomy of coronary architecture. And while that's been incredibly helpful, particularly in understanding how to use stenting, it turns out that it really is not a complete tool to be able to understand the complications that occur in coronary arteries due to plaques and stents. So we have in our experimental lab and now clinically translating a new form of imaging called molecular imaging, which is this goal of imaging specific molecules and cells in coronary arteries inside living patients. And the reason we're interested in doing that is we're trying to actually understand the impact and importance of inflammation in driving plaque complications and stent complications. And until now, we've not really had a way to image inflammation inside human coronary arteries. We image the structure, we image anatomy. So how do we image biology? It's really through this form of using fluorescence molecular imaging. Imaging agents that bind specific molecules or cells, they're injected, and then they bind to a stent target, such as fibrin, or they bind to another stent target, such as inflammatory enzyme. They create local fluorescence, and then we bring a catheter in, just like we bring with ultrasound or OCT. We bring an intravascular fluorescence catheter in to detect the fluorescence signal within the plaques or within stents. We've now been able to combine fluorescence with OCT, so we have a combined integrated molecular structural imaging device. So you really get two for the price of one, but they're very complementary, biology and structure. Today at the ACC, our postdoctoral fellow, Eric Osborne, is presenting this first demonstration that one can use the inflammatory signal within a stent to predict restenosis. And not even just predict it within a stent, just as a stent binarily. We can tell you exactly where in the stent you're going to get scar tissue forming. And this is experimental in rabbits. We've implanted coronary stents, 3.5 millimeter diameter stents, and then a week later, imaged their inflammatory response using intravascular fluorescence OCT. And then 3 weeks after that, we re-image them and we compare where was the inflammation signal at time 1 compared to the structural restenosis signal at time 2. And there is a tremendous match. If one is inflamed, if part of the stent is inflamed, and typically it's at the edges, 3 weeks later, that's where the scar tissue forms. Looking at this is really some of our first time. When people implant stents, they have no idea if it's going to restenose. Restenosis is still a very powerful complication of coronary stenting. It happens much less with drug-eluting stents, but it's still 5, 10, 15%. And sometimes it happens late. And when people have restenosis, they're going to have recurrent symptoms. Sometimes they have recurrent small heart attacks, and they require repeat intervention. So it's not a low morbidity event. If we have the ability to now predict this based on the inflammatory signal, it's maybe going to allow us to identify patients who are going to be at high risk. Maybe they're going to get adjunctive therapies. Maybe for companies who are trying to figure out why did my stent not affect restenosis as much, they're going to have a mechanistic insight. They're going to say, wow, there's a lot more inflammation in stent A compared to stent B. Maybe we should be changing our stent design. Maybe they need additional drugs on their new stents. Those sorts of things now, we're going to have a pivotal, entirely new way to change that using intravascular fluorescence in molecular imaging. And this is not just an experimental technique. We've now done first-in-human work at Massachusetts General Hospital using fluorescence OCT imaging in living patients in our cath lab. We've done 12 patients, and some of that work has been presented recently, and we hope to have a publication about that very soon. So this is really moving into the clinical arena. We think that for understanding physiology, pathophysiology, things that happen bad in terms of stents and plaques, this is going to be an incredible clinical research tool to understand the natural history of plaque and stent complications. But how's it going to affect patient care at point of care? That's what you're really asking. And we think that we're going to be able to tell people at the point of stenting if they're going to be in a high-risk restenosis environment. And that might change them. If you're on the fence between bare metal and drug-eluting, maybe that's going to tip you towards drug-eluting. If you're thinking of using adjunctive pharmacotherapy, maybe that's going to say, with a high inflammatory state, we should be more aggressive about ejective. There are some new agents that might prevent restenosis systemically. Another thing that one might say is, gosh, maybe I should be using the structural part of my imaging to make my stent better. There's a lot of new imaging, there's a lot of new interest in imaging to optimize stents. And more data, if we look at it on a meta-analysis, suggests that if we use image guidance to deploy our stent, we're going to get better long-term outcomes. So here you're going to have both the biological motivation to do it, and then if you combine it with OCT, you'll have the anatomical way to improve your stent. So it might really be a nice way to improve our outcomes. I'm really pointing.